Welcome everyone to this evening's first of our series of public meetings addressing the demands identified in the Race Equality Report, which was produced by the Commissioner in January 2022. All of the recommendations and demands were accepted by the Ealing in February 2022. My name is Denise Charles and I'm the chair for the Citizens Tribunal. The Citizens Tribunal was appointed to hold the council and its partners to account for the delivery and demands of the Race Equality Commission. The Citizens Tribunal is made up of 10 members. Each of us bring our own individual skills, expertise, and in particular our lived experience that reflects the priorities areas of the report. This evening is our first meeting addressing demands around the health inequalities. This meeting is very important to me personally as it represents a critical milestone. I was one of the original group of commissioners led by Lord Simon Woolley, looking at the issues and challenges around the inequalities which led the report and its findings. Being able to witness and be part of the solution, helping to drive change and witness the council and its partners are working to put actions into place to address the inequalities, and in particular, the race inequalities, is why I wanted to be part of the Citizens Tribunal. You will soon hear from the Ealing Public Health and North West London ICB officers about the work they're doing to address the demands identified in the Race Equality Report around health. You will also hear from the Citizen Tribunal Health Subgroup on their role in scrutinising and reviewing the health response. Members of the public viewing at home, this is also your opportunity to ask questions and to comment on what you're hearing by using the chat function. Office of the council, Peter Mason, to say a few words. So if I can hand over.
Yeah, happy to go first. I'm Simon Crawford. I'm Deputy Chief Executive of London North West Healthcare Trust. The Trust is responsible for providing acute care in Ealing Hospital, Northwick Park Hospital and Central Middlesex. And my responsibilities include strategy, transformation, digital services, and indeed partnership working. So I'm a member of the Ealing Integrated Care Board as well as Brent and Harrows as well. So that's my focus and remit. Glad to be here this evening.
Thank you. My name's Chris Hilton. I'm a psychiatrist by background and work as the Chief Operating Officer in West London NHS Trust. West London Trust is the mental health and community health provider for Ealing. And in addition, we provide mental health and community health services in Hammersmith and Fulham, Hounslow, and a range of specialist mental health services elsewhere, including at Broadmoor Hospital. I really welcome the opportunity to share the work that we're doing with the panel. And I also ought to say that in addition to my work with West London Trust, I have a role as the director of the borough-based partnership for Ealing, working alongside Neha and other colleagues here.
Thank you. My name is Neha Unakat. I am the Borough Director for Ealing, working as part of the North West London Integrated Care Board. That's the ICB that you mentioned earlier. So I am here, but we've been working with all of the partners to put all of this information together and analyse the data and collate our collective action plans, and we'll be able to talk through a lot of the detail.
Hi everybody, I'm Anna Bryden. I'm Director of Public Health at Ealing Council. I'm really pleased to be here.
Hi everyone, I'm Susu Kumaran. I'm an Ealing resident and a member of the Citizens Tribunal. I'm a consultant child and adolescent psychiatrist by trade, and many moons ago had the pleasure of training and starting my consultant career in Ealing. I'm currently working in a different borough in West London, but obviously I'm still very interested in what happens here. And I also have a particular interest in human rights and equality, diversity and inclusion.
Hello, good afternoon. I am Dr. Munir Abbasi. My background is engineering, technology, data determination, and impact evaluation. I did a number of projects in healthcare and social innovation. I am a member of Citizens Tribunal, and I am also a school governor. I also believe in participatory approach, and I think it's important for us to engage citizen in decision-making process. So that's why I am here today. Thank you.
Thank you.
Hello, thank you. My name's Angela Mackenzie. I live in the borough of Greenford. I've lived in Greenford for about 30 years. I work for the NHS as a primary care commissioner. I've been working in the NHS for over 25 years. I'm the chair of the health subgroup, and my reason for joining the subgroup was to actually look at the services that are being delivered to Ealing residents, because that's of interest to me. And I think we're at a stage where we need to hold organisations to account who are delivering services to residents. Thank you.
I'm Nina Singh. I'm Chief People Officer at West London. Chris has already described the services that West London delivers. I lead on the workforce response to race equality on behalf of the organisation. And like Angela, have had the pleasure of working in the NHS for over 20 years.
Good evening, everyone. I'm Vijay Ped. I'm a GP in Acton. I'm the Borough Medical Director for Ealing, providing clinical leadership for the borough, but also for North West London ICB. I'm also joint chair of the Borough Place Partnership, and prior to that, I was vice chair of Ealing CCG.
I'm Aisha Raza, and I'm the cabinet member for tackling inequality in Ealing. And on my day job, I teach healthcare professionals. So this is doubly interesting for me.
And do we have Peter Mason on the line? Oh, okay. Okay, so we've got Councillor Josh who's going to say a few words for us.
Evening, thanks. So I'm Councillor Josh Blacker. I'm the Cabinet Member for Healthy Lives. So looking after public health, adult social services, and the Council's partnership with Chris and Simon and others, and BJ and Neha around the table, all our health partners as well. So I think Councillor Mason is not able to join us. So if I'll try and say what he would have said for you. But first of all, thank you so much for joining us, and thank you particularly to the members of the tribunal who are around the table. I'm particularly, obviously, Peter's thanks to you as well. So obviously at the beginning of 2021, we published the findings of the Race Equality Commission, and the demands that they made, we are taking incredibly seriously, and we are actioning them because they are demands that will make Ealing a fairer and more equitable place to live. Obviously, one of the demands was to establish this tribunal, which has been written into the council's constitution, importantly, so it's not something we can just toss aside and ignore. And your role is obviously to hold us to account for the progress of those demands, ensuring you keep our feet to the flames. We want you to do that. It will be a difficult process for us, I expect, but it's important that you do it. So thank you for your dedication to this process. Thank you for the hard work you've already put in, I know, behind the scenes before this first public meeting. And thank you for providing your expertise and particularly your lived experience in stepping forward to take up the change of holding the challenge of holding the council and the partners around the table to account in delivering the demands that the Commission made. We know as a council that we cannot deliver on all of those demands alone. We also know that those actions alone will not achieve the changes that are needed, but the actions accompanied by deep cultural change, that is how we tackle embedded inequality. So this evening is the start of a very long journey with this first tribunal meeting. So thank you once again, and I look forward, and we all look forward to working with you all on making Ealing a fairer place for everyone.
Thank you, Councillor Josh. We now move on to the main section of the evening to hear from Ealing Public Health and North West London ICB, having their responses to the 3 demands stated in the report by hearing about the actions they have started to put in place and those that they plan for the future. So I'm now going to hand over to Angela.
Thank you, Denise. So as a panel looking at the priority group for health, we have met on several occasions to look at the action plans submitted by representatives from both local authority and health. As a panel, we have used our expertise within the field to scrutinise the data that has been submitted. And from that, we've pulled together follow-up actions, and we've also asked for additional data with regards to the 3 demands. With regards to our scrutinisation, we've all taken a lead role in each of the demands, and my panel members will cover each of the 3 demands. As a panel, we're sure that this is just the beginning of the journey, and I think we need to make that clear. But one of the things we want to do is to make sure that the actions that have been stipulated within the plans are met, and we as a panel will make sure that Ealing local authority and health are held to account for the actions that they have addressed. So if we just take each of the individual demands, the way the meeting will take place, the format of the meeting today will be, we will cover each of the demands and we will allow 10 minutes for presentation, and that will be followed by 15 minutes for questions from the general public. So what I will do, I will just give an outline of the first demand. So demand 1, what the recommendation was for the organisations, both local authority and health, to look at the representation of Black, Asian and minority ethnic groups within their workforce, especially within senior leadership roles. And what we wanted to do was use the data and use the information provided by these organisations to see the ratio of people employed within these organisations and those within senior leadership roles. So as we go into the presentation, they will respond to how they've addressed that individual demand. And if my colleague will just talk about demand 2.
Okay, thank you. So demand 2 relates to COVID, and what the Race Equality Commission has said is we must learn the lessons from the pandemic, that the Health and Wellbeing Board carries out a review of how Ealing dealt with the pandemic and ensure that the lessons learned are made public and acted upon. Shall I say a bit about our thoughts? Yeah. So if I move on to, so in thinking about demand 2, we did have helpful data from our health colleagues. And we noted that there was a lot of information from the first wave, so 2021, 22, but less from the second wave. It was clear that in the first wave of the pandemic, Ealing had figures that were worse in terms of infection rates, hospitalization, and deaths, that were worse than the London average and the national average for England. But these figures were closer to the national averages and London averages in the second wave. And in that first wave, we noted that the worst affected were the Western boroughs, and these were the boroughs with the highest proportions of people from ethnic minorities, who were in low-skilled jobs, who were in overcrowded housing, and who had comorbid health conditions. So all the risk factors for COVID were very high in those boroughs. We were pleased to see that the council had sought, and health colleagues had sought feedback about services from residents who raised concerns that pre-pandemic health improvements that had been made were lost, and that communities were already struggling with racism were less able to do so during the pandemic. And there was a lot of positive feedback about Ealing Together, community network that was set up during the pandemic. So our questions are really, could we have further analysis of data from the second wave, which is coming through? How findings from the national COVID inquiry will map onto Ealing? I guess details about the way Ealing has talked about system-wide practices. So we'd like more details on that. And a particular question about the vaccination program, which was felt to be a success in Ealing. So what are the lessons from that, particularly about access, improving access and information for underrepresented groups that could be taken forward to future public health initiatives and vaccination programs? Thank you.
And demand 3.
And demand 3 is more about the funding priorities and also about the what resources are available across Ealing based on different projects and initiative in place. So basically, we are looking some of the local initiatives which are already in place, like a community champion programs. And we suggested to also evaluate these programs to see their effectiveness, added values, and also impact on the community, whether and these initiatives are basically targeting the health inequality area and their objectives, what are their objectives, and whether they have achieved their desired outcome or not. So based on this and lesson learned, what we'll do, so we will evaluate the fundings, and we will also see how future programs and strategies can be more competitive based on openness, and also to provide the further support to the communities to overcome the health inequalities, also so that no one should be left behind in health and structures services. And also NHS Core 20+ strategy was shared with us. This is our national NHS approach. We suggested to implement this approach on local needs and priorities to tackle the health inequalities and key focus health areas such as maternity, mental health, cancer, diabetes, and also hypertension. We also suggested to measure the performance of NHS services and structure to see the accessibility, availability, and effectiveness, so that this will help to reduce the health inequality within communities and across different towns where higher proportion of Ealing minority community is living. We are also looking the COVID-19 initial impact and lesson learned. Some impact data was shared with us. So we are looking forward to see effectiveness of COVID-19 vaccine strategies, best practices, and lesson learned across Ealing. And these outputs can be useful for us and also to see the future strategies. And also these can be useful for vaccine preventable immunization, covering awareness and also the behavior change, so that the health inequalities can be addressed across Ealing. We are also looking forward to see the health and well-being policy, which we was informed that is in progress, and we expect it will cover the priorities based on communities' needs, as well as to help reduce the health inequalities. Thank you.
Thank you very much. Thank you. Okay.
So I'll just reiterate, so the way the programme will go now, we'll get a response from our representatives from health and local authority, and they will address the demand 1 workforce. And I'll just repeat what the demand 1 workforce: the Commissioner of Services to draw up a clear strategic plan for greater representation in both health service provision and the leadership position in health services of communities in Ealing, particularly the African and Caribbean communities. So the way that will be, our colleagues will have 10 minutes to present, and then we'll have 15 minutes for questions that come through from the general public. Thank you.
Thank you very much. So I will take us through some slides that we've prepared. We'll just get them on the screen. Thank you very much. So the first section is as described around the workforce, and we've already provided a lot of information to the health subgroup of the Race Equality Commission. And we've had a meeting before. We've started to go through some of that data. We've had additional questions come in following the analysis. And so what I'm going to try and do through this set of slides is explain a bit about some of the overall information that we have seen and some of the actions that have, some of the actions that have started to be put in place across all of our providers and the Integrated Care Board as well. And then start to share some of the impact that's already started to be seen. And that's where my colleagues will come in. I think there's a couple of things for introduction purposes I wanted to just specify. So the CCGs, which is a clinical commissioning group, was set up in 2013. And before that, there was something called primary care trusts. Now we're an integrated care board, we're part of the Integrated Care Board. When the commission was reported on and the actions accepted, we were a clinical commissioning group, which was a GP-led, clinically led commissioning organisation. And the recommendation was focusing on the clinical commissioning group's workforce, but also primary care clinicians, because they were the leaders of the commissioning function. However, as we are an integrated care board, what we've done is widen the scope of the review, which is absolutely right, for all of the workforce that is supporting the population of Ealing across all of our providers. And I think the fantastic thing is that this is a national agenda as well. And within the NHS, there is something called model employer goals, where the ask is that over a short period of time, actually, I think it's by 2025, is to ask and get all of the boards representative of the local population. And so part of that is an understanding what the makeup of the local population is and what the profile of the population is. And you'll see some of the key findings. And in this slide, which I'm sure will be available at some point, we've looked at 3 years worth of data, but we have some more recent data, which I'll share in a moment. And you've got the links to the national surveys that are available there. Go to the next slide. Thank you. So some of the key messages from the initial data presented was that there is a level of diversity across the whole of the NHS, but the level of diversity is higher in the workforce in London compared to national, which is a good thing. But as we've looked in the data, the more senior the role, the less diverse the leadership becomes, as was the premise in the original report. And our data does present that very message. However, there are a lot of actions that are being undertaken at the moment in each of the trusts to really try and shift that and change that. And there's variation amongst every single organisation. What is also really positive to see is that in Northwest London, our workforce profile is very representative of our local population, so as an overall. But as I was, if you go to the next slide, you can see, so that the graph at the on the top right-hand side is the lines show the census information about our local population, the profile of our population, and the lines, the columns, are the different organizations and how representative they are. So we were asked, we provided this information to the subgroup for the local authority. And we were asked about whether we could do the same for the integrated care board, and that this is the data that has come out of that. So this is directly in response to that. And it's in exactly the same profile that you're seeing in the local authority, but also our local providers, because we've done similar analysis across our providers as well. However, the bottom left-hand graph, the more senior the roles are, the less representative they are of our local populations. Again, so the left-hand, so the columns show the different ethnic groups. It's not broken down totally in the different organizations against the census for the more senior roles. So if you go to the next slide. There are a number of actions being taken across all of our organizations. And actually, when we've looked at all of them, they're very similar, and there's some really core planks of work that's happening across all of us. So we're all looking at reviewing, we're all looking at our recruitment processes and the panels and making sure that they're representative, and making sure that we're doing what we can to have unconscious bias training or champions that are sitting on those panels to make sure that the process is absolutely fair. All of our organizations are looking at a BAME talent pool and supporting them to become future leaders and giving them opportunities to take on more roles. And we're looking at targeted leadership development for individuals as well, and mentoring and support for those. We're all working on staff networks such as BAME and LGBTQ, and it's really important that not only are we looking at, not only have we set these up really successfully and they are representative and very well attended, but they are empowered to have a voice and call out where something isn't working or isn't fair. And then listening to our workforce and tackling bullying and harassment and strengthening what we call the speak up processes. And targets around increasing percentage of BAME staff that believe our organisations provide equal opportunities. And it's very similar to some of the actions that are happening in the local authority. So I've included those here as well, about positive action group for aspiring leaders that was launched in 2021 and is going to finish in 2023. And there's learning from that and as to about career progression and what next from there. So when we look at all of our organizations serving the population of Ealing, actually there's a real targeted effort to try and address this. Just go to the next slide, and maybe this is where my colleagues will like to come in. But this starts to describe some of the outcomes so far. Did anybody, Nina, did you want to?
Shall I add at this point? So Neha's given as a collective some of the theme. Sorry, I'm Nina Singh, Chief People Officer, and on slide 8, what Neha has done is used West London as an illustrative example of some of the workforce interventions. Neha set out a clear picture of, you can see the workforce is diverse within our organisations, but if you look at the senior leadership, it isn't. But what we can see also from the data is over the last 3 years, we are becoming increasingly diverse. So the workforce interventions that have been put in are having impact. All of the health providers within the ICB have agreed that we will work to model employer goals so that we are all meeting a 50% BME target by the year 2025. And some of the things that we've done in West London are set out in slide 8. Specifically, what we believe has made a real difference in accelerating BAME leadership at senior level, includes having a specific BAME development program, which is for us an award-winning program, and 50% of the participants in each cohort have then gone on to a higher post and receive promotion. Sometimes within the organisation, sometimes external, but within NHS organisations. We've also established specific leadership posts because the feedback from our BAME colleagues is that if you never get the opportunity at senior level, how can you demonstrate at interview you've got the skills? And it was a comment that came back again and again and again from our colleagues to say, in order to have a leadership team that looks more like me, looks more like you, actually we need to be given opportunities for development. So what we did at West London is we invested in 3 leadership posts and have developed those individuals who subsequently, 2 of the 3 have gone on to achieve promotion, which is exactly what the program was intended to do. But I think one of the most impactful things that we've done is change the way we recruit. So on each of our senior recruitment panels, we have somebody who's been trained as a diversity champion. We want to see evidence that people are committed to the same diversity goals that the organization is interested in pursuing. So we want to see evidence of that commitment, but we also want the candidate to see that we are a diverse organization. We welcome diversity. We think it's one of our strengths. And so by having a mixed panel, we want to make people feel comfortable with the kind of organization we are. And hopefully by demonstrating our values, they then have that same commitment when they come to work for us. We think the combination of the 3, I can't say it's any one particular, by having the suite of the 3 initiatives, what we have seen over the last year is our BAME leadership has gone from 32% to 40% in 1 year, whereas our overall workforce has only grown by 6%. So the acceleration of our workforce initiatives, certainly in year 1, shows that it's really having the desired impact. And we have surpassed our model employer goals for this year. And we are moving towards that 50% marker. And all of us want to do that before 2025. You don't have to wait for that to happen, for that day. And if we can get there faster, that certainly would be our ambition.
Thank you, Nina. Sam, did you want to say anything?
Yeah, I'm happy to say a few words, and I think West London has probably got a few things that we could learn from in terms of the progress that you've made. Maybe we're just a bit behind you in terms of starting that journey. But one of the significant things that we've done this year is develop a new trust strategy, and we did that with a very inclusive engagement process with our staff, but also with our communities. And one of the things that came out of that, our 4 objectives are about being high quality, timely, equitable care in a sustainable way. So the equitable care, so it's about equity of care to patients. I know we'll talk about equity a bit later. But a high quality employer being all our people belonging and empowered to provide excellent services and grow their careers. So a real focus on BME as part of developing them. And I think part of the way of addressing that is collecting and monitoring the data. So we're much better at collecting that and monitoring that data now in terms of the representation of our workforce in the grades and taking positive action to address that. And so one of the things that we have said is that we will work to be an anti-racist organisation, and that's a really positive statement. It's more than just about equity. It's about proactively being anti-racist and rooting out anti-racist behaviour and focusing on our leadership teams and our management. Because I think one of the things is we promote people as a result of service into higher management posts, and quite often they're not always equipped with the right skills. So there is a focus for us in terms of supporting people to be more empowered leaders, but also more empathy and understanding. I think things like having difficult conversations with staff and stuff, and how you do that. Quite often it's not the what, it's how, and how people feel as part of those processes. So that's a real emphasis for us. We've got a very active independent staff insight group, and that's led by our staff and staff from a BME background, and those are monthly meetings, and we regularly have something between 100 to 200 people attending those, feeding back to the organization. And I think as well as that, we've got the similar sort of cohort of leadership development programs to support people. And again, that's on the slide pack around the Progress 2 to 7 programs. And 21% of those are progress into high roles. You've got 50%, but we're probably early days. So hopefully that will improve. And we've got the band 5 learners or 5 learners on substantive band 7s have been supported into band 8A roles to try and support and develop them to move through that management role. And also then in terms of our strategy development, we sought out people from a BMA group and seconded them in and supported them to work differently, give them a different experience. And we've got an internal transformation team. And again, we focused on recruiting people into that team from a BME background. So all of those things, I think, are aimed at trying to change the culture and what it feels like to work in London Northwest. But, you know, we're still very much at the start of a journey, but hopefully we are targeting in the right areas. And we do have the network groups like the BME network group, like a disability inclusion group, etc. as well up and running.
Thank you very much. Thank you. We're going to take some questions now from the general public. I'm
still going to say just one last couple of things. Is that right?
Okay.
Just last couple of things.
Problem.
The original commission asked around primary care data as well. And as you know, a lot of our patients go to primary care as a first port of call. However, nationally, there's a real difficulty in getting that data in a sustainable way, but there is a program to collect this information nationally for primary care. So when that becomes available over a couple of years, we will absolutely keep bringing that back to here, but that is very much one of the areas. And then the only other thing that I wanted to add was, you know, there are staff surveys done nationally. The ICB, the Integrated Care Board, along with our providers, all our workforce, all report into that. And what I've done in the slide there is just show you one question in particular, which I think is quite representative, about does your organization act fairly with regards to career progression, promotion, regardless of ethnicity, background, gender, religion, sexual orientation, disability. And what we saw from the survey results is the ICB didn't come out very well last year. There has definitely been an improvement in this 1 year, but there is so much more to do, and we've got to learn from organisations who are doing really well, like West London NHS Trust and London Northwest. But there's just still so much more to do around this journey. So that was it. Thank you.
Thank you very much. Thank you. So we've got some questions from the general public, which we'll have read out, and then we'll nominate somebody or someone can volunteer to answer the question that is being posed.
Okay, we've got quite a long. Chelly Shahal has written questions around ophthalmology and the contract, but I'll read it out because there's quite a lot there. So I don't know which one of the panel members will take. So she says, raising the critical priority health issue of adequately and seamlessly progressing the secondary care provision of community ophthalmology, which for the past 15 years, since 2009, has been delivered in the Ealing and Hounslow district by Operose Health. It is understood that the subject commission, having been relinquished with effect from the end of June 2023, is being replaced by a new, apparently downgraded contact, whereby instead of the highly skilled, experienced, eminent doctors, or CAPS, with eyesight specialism, who accordingly have expert knowledge about the adverse impact, e.g. hypertension, diabetes, and eyesight conditions, have been identified to particularly and disproportionately blight the lives of the local population going forward. The newly assigned practitioners will instead be opticians. Though opticians deliver vital health management services, secondary care requires specialist expertise. I think the other one's slightly linked, so shall I just read the second part again? Localism is about making such specialism closely accessible instead of patients having to attend Moorfields Eye Hospital or Western Eye Hospital in London, which through this seemingly diminished contract will not be achieved. There does not appear to be any deficiency in the provision of local optician services. which are adequately provided through private enterprise, but there is a need to continue the secondary care specialist provision that presently serve circa 9,000 patients. Kindly review the agreed contract with Evolutia, which should include a requirement for equivalent provision to be maintained as per present delivery, so that the specialist doctors that currently deliver continue. Please. That's very, there's one more after that, which I'll read out.
Thank you. I think it will be most appropriate for Dr. Taylor to take this one.
Yeah, so I'll take this one. So Opros, as you all know, has been a community ophthalmology provider both for Ealing and Hounslow for several years. Opros made a decision to actually move their business and their service delivery away from ophthalmology. So this is a decision that Opros made in terms of their future provision of healthcare and in terms of what they want to provide going forward. So clearly for us in Ealing and in Hounslow, we needed to make some decisions as to what would be the best way forward. We need to also remember that not all boroughs in Northwest London had a community ophthalmology service. In fact, there's only 3 that had it. That was us, Hounslow and Brent. The other 5 boroughs primarily had the acute services for ophthalmology. So there was that disparity across Northwest London, and hence Northwest London have been working through a community offer across Northwest London, not just only for the 5 boroughs that didn't have a service, but all 8. And it was important that we had equal access of delivery. And to do that, it was important that we utilize and maximize the workforce in ophthalmology to enable us to do that. So the procurement and specifications currently being developed, which will be primarily a optometry-led service across Northwest London with clinical supervision and oversight from consultant ophthalmologists from all of the acute providers that we have in Northwest London, including Imperial, Chelsea West and Moorfields. So for Ealing itself, we clearly now have a gap in provision that we are currently trying to work through, and we have started to explore and source out potential community provision that would ensure that we continue to maintain the level of service that we require. And clearly, it's important to understand there are not many community ophthalmology providers out there nationally. And, you know, in fact, when we previously went out to procurement again, we had an unsuccessful procurement because of the fact that there wasn't those providers out there. So Evolutia is a national organization which have various community ophthalmology services across the country. They are on the ERS framework, so they have set themselves up in Park Royal to deliver community ophthalmology services. We have started to have conversations and dialogue with them to enable them to support Ealing and Hounslow in terms of providing services for both those boroughs, and also exploring whether another local service called HealthShare can also help us in that regard. This is a progressive approach that we need to undertake. We clearly have to ensure that the population that's currently being served by Opros, particularly those who have chronic glaucoma, maintain that level of monitoring and supervision. So that's going to be very, very important. But going forward, any new eye condition referrals, that there is choice for the patient, including the acute services, which are still there and established. And so we need to ensure that we don't compromise any service delivery. It's important to understand that we want to try and ensure that we have a equal service and ophthalmology conditions right across Northwest London. That is the priority for the ICB, because of the fact that we have had some level of fragmented service for a number of years. And so that is our key goal, to ensure that we can do that, so that patients who require a community provision are able to do so. And those that require highly specialised eye care go to the right places, which is our acute providers that we have in North West London.
Thank you very much. Thank you. We're going to take one more question.
Yeah, this is specifically for workforce
Okay.
from Steph Ajay, one of our tribunal members. And Steph says, how do you ensure diversity of cultures when looking at representation at senior levels? We could get representation, but find that they are mostly from one cultural background. How do you guard against this and embrace all cultures?
Who would like to? Thank you.
So it's a fair challenge in the question. Absolutely. So I did refer to the fact that we are monitoring the data, and so having a clear understanding around data and what representation we have got in the different grades. And I suppose what we are trying to do is encourage and support applications from all BME representation groups, whether it's Asians, whether it's Black Africa, Caribbean, etc., and to support them in equal ways. And I think, yeah, it's only going to change by us monitoring, supporting, and encouraging. And we do have the diverse panels as well. And we have had a process where we don't select someone from a BME panel, then there needs to be an explanation as to why we're not selecting people from a BME panel as well. But I think it's monitoring and holding the mirror up. I think is the reality, is the only way it's going to change.
Thank you very much. Yeah.
So I would agree entirely with Simon. I would add, the only thing I would add is from the monitoring and data, what we've certainly done at West London is look at what that shows us, to look at when we are recruiting, do we need to focus on a particular area? And if we look at board representation, for example, we're working up to being representative within West London of our local communities. We're just one board member short. But within that, what's very clear is all of the BAME board members are Asian. And there isn't diversity in terms of board members from a Black background, and that is problematic. So the detail matters. So when we're doing the analysis and the data and the monitoring that Simon's alluded to, it's about the understanding the detail behind it, so we don't lump all BAME groups into one lump sum, and we actually deaggregate, if that's even a word, and look at it, look at the detail to understand, therefore, where do we next need to target?
Thank you very much. Thank you. I will now bring demand 1 to a close, and if we can then move on to demand 2, please, Angela.
Thank you. Before I move on to demand 2, just to say that I think there was a message in the chat to say that they couldn't see the actual slides, but I've been told that the slides will be uploaded onto the council's website, should people want to review them later on. And one of the things I'll also mention is that we do have quite a few questions in the chat. So I think what we will try and do is a Q&A after this session to make sure that every question is answered. Okay, moving on to demand 2. This is us addressing, or the organisations addressing, the learning from COVID. And what the report request was, we must learn from the lessons of the pandemic, that health and wellbeing boards carry out a review of how Ealing dealt with the pandemic and ensure that the lessons learned are made public and acted upon. Thank you.
Thank you, Angela. Just for people that were joining since the beginning, I'm Anna Bryden, Director of Public Health at the Council. I could talk about COVID for days, so I'll try and keep this short. I think this is something we were planning to do anyway. I think the rec demand on this really has pushed us forward. And we'll just talk through this. I think it's really valuable and something we absolutely need to do across the system. So just a bit of the background. My team in the council is leading this on behalf of the Health and Wellbeing Board. So the Health and Wellbeing Board have essentially accepted this recommendation and taking it forward. It's at a draft report stage, so we've been doing a lot of work on it over the last few months. That's taken the form of sorry, my water bottle is slowly exploding. There we go. Sorry, that was weird. Apologies. That's taken a form. We've been analysing a number of service reviews. So, for example, our vaccine services, our testing services, contact tracing, everything that seemed very normal a couple of years ago. Undertaken some data analysis, tried to update some of that inequalities data, and also surveys, interviews with a lot of different teams. We're now at the stage where we're trying to just, we have got a draft of that when we're almost taking it back to some of our teams as some groups and really reflecting that back together to make sure that we've got it right and that everybody's on board with that. Just to, on the data especially, just to go back to Sue's, the questions and themes that Sue mentioned at the beginning, some of them will be answering here, some of them under theme 3, just because of the way it flows, but we're definitely covering them all. And then just to say that lessons learned review focuses on that response with the pandemic, but very much on the what learning can we take forward across our partnership. So in roughly 3 themes. So one is what happens if we get another pandemic? What happens when we get another pandemic? How do we take that forward? Are the specific learning around things like contact tracing and testing, partnership working, I think massive learning there, and then more on the inequality side. So we've definitely taken a focus on inequalities through that lessons learned review, and you'll see that coming out, and we're aiming for Health and Wellbeing Board, I think in late June, to take, that's our current plan, and then obviously action plan to be taken forward from there. So because this is still in draft form, these are very much emerging themes. These might, when you see the final report in a few months, these might be slightly amended. There might be other ones, but these are the kind of general things coming out. Just going to talk through them really briefly and before we go into questions. So the first one was absolutely crucial in this, doing community engagement well. And in lots of different ways, building up that trust, leaning on the relationships that people like our engagement team already had, working with our community leaders, had such a key role in sharing those key messages. And I think importantly, having that 2-way conversation, that feedback loop in terms of what was landing well, what was still a challenge, what was unsure to people, was really, really crucial at various stages. We also had the benefit of a relationship with some academic partners that came and worked with us in terms of vaccine equity and vaccine hesitancy, and really having conversations both with adults and young people. So that was really fantastic. And they're now working with us to train up some peer researchers. So it's really nice to see that work move from a kind of COVID response phase into something much longer term. Second one is really crucial as well, and is something where we've been taking the learning along already. It's not something we're waiting for this review to do. Examples of this would be things like communications, the importance of translating materials. A lot of the materials that came from national government were very much in English, and we took upon ourselves to do translations of that into our main community languages where we could, or translating kind of social media messages and things, because that came out as a really crucial thing from our communities. And then vaccination programs, lots of learning around this, but we did provide some of the COVID vaccinations in, say, specific locations with support of local community voluntary faith sectors. So, for example, we had the bus at the Big Goodwire in Southall. There's learning from that in terms of how important it is to have both a kind of really good, robust, universal offer, but also targeted offer on top of that. There's also really practical learning about how hard some of that is, and the benefits of that, and really thinking through that balance as we go through. And we've already taken that through in terms of polio vaccination programs and things. It's not something kind of, like I said, we're waiting to learn, but I think there's really good learning to take forward there. Communication, simply in terms of it being timely, really broad range, trying out different methodologies. There was a lot of work we did in terms of social media, getting things out through community leaders in terms of WhatsApp groups and just letting things run organically. So interesting, trying things in a different way than we've done before. Team and partnership work, and we had lots of positive reflections from people about support from their own teams, but also across our partners. That was really important in terms of flexibility, staff well-being all the way through the pandemic, and also learning about structures. So how did we do that partnership work and how would we do it in future? And I think that has actually really helped kind of us as we've developed the borough-based partnership in terms of how we do that together. Data, lots of things under here. One of the really important things under here was that at very early stages, there were legal issues why we couldn't share certain levels of data. And then as we went through time, realised that a lot of other boroughs were actually starting to almost ignore that and share data earlier than we did. And then we were getting a lot of challenge from our communities, rightly so. So we were trying to share summary data, but it did sound like we were trying to hide something, which was never the point. So there's just learning that from there about how could we have communicated that differently? How could we have made decisions, etc. And also about data management. So for example, a lot of our data for say contact tracing was done on Excel sheets. And just thinking through or school outbreaks examples, excuse me, just thinking about how we do that more robustly if we need to do it together again. Processes and procedures, there's lots of different things under that, but one of the examples would be, for example, when we were having to do testing or vaccinations, we were scrabbling around trying to find sites between us, trying to close other services that were using those sites, and just really thinking between us, if we had to stand something up really quickly, what sites will we be looking at? What are the impacts of that? What are the practicalities? So just thinking about having that in advance. And similarly with workforce, what skills and knowledge do we need to build up around the system in terms of basic emergency management, basic health protection, and also thinking about redeployment, especially in the council. We did a lot of that through volunteers in different teams, but actually other councils did it through redeployment policies for say staff in libraries who were all furloughed at the time, and just really thinking about how we might do that going forward. I think that's all I was going to say. There's a lot there obviously, but very happy to take questions.
Did anyone? Yes, someone wants to add something first.
Yeah, and so the other thing I would say, because part of the question is the difference between phase one and phase two of COVID. And I think we mustn't forget that in Northwest London, we were in the eye of the storm in terms of being the first to have COVID on the scale that it was. So there was a lot of learning and a lot of not knowing, I think, right at the start in terms of the COVID presentations, how seriously unwell they were, how they degenerated very quickly, what were the appropriate drug regimes. And we learned quite quickly in terms of the different treatment regimes, the need to isolate, the different combination of drug therapies that may work, the importance of access to critical care quickly and expanding our critical care. And what I would say is other areas outside of Northwest London benefited from the experience in Northwest London. So in any kind of final report, I think we need to capture that. And I'm probably not the best person to give the clinical story, but someone like Lawrence John, our head of infection control and stuff, who was at the forefront of looking at some of the innovation and what we did differently, would be really helpful, I think, to have a conversation and feed that in. And then again, with the first wave of the pandemic, there was learning and access to things like preventative clothing and masks and all those kind of things, and the demand and supply, and also flipping staff from different roles. That they were learning those new roles. We were taking people who weren't used to working in critical care and turning patients and that kind of stuff. By the time of phase two, people had learned those skills, and we were redeploying the same people into that. And by phase two, of course, a lot of people had benefited from the COVID vaccines, etc. And there was a degree of resilience, and so they weren't the percentages presenting as critically unwell weren't quite as high as they were in phase one. So those are some of the factors that draw a distinction between what was different between first wave and second wave.
Thank you very much for that. Thank you.
Thank you. And I would just add a few other things as well, and that we've taken on as learning and implemented in the system. So Anna talked about the data, but also partnership working earlier on. And actually, as a system, as a North West London system, when the vaccination program started, but also our coordination across the whole of North West London between local authorities, all of our health providers, working with the voluntary sector organisations, that just became stronger and stronger and stronger. And without that co-working and support to each other, including staff from the ICB who were going out and working in the hospitals to support the frontline teams or setting up the vaccination clinics, that data that then also started to become available across the whole of North West London around which populations were accessing the vaccine and where there were gaps emerging about who was taking up the vaccine and who wasn't, we were able to quickly then work out where we needed to stand up additional clinics. And that's where our bus came in Acton, or the Saturday clinics in one of the schools in Acton and things like that. And we continue to have North West London wide conversations about like for polio, for example, or even the vaccination programs, spring booster programs about to start now, but also our coordination in response to the strikes. We've learned about how to work together as a system. So that's all of us working collectively in a very different way to what it was before COVID.
Thank you very much. Thank you. And do we have any questions?
Yes, we've got one specific from Rosalind Lord on the vaccine. She says, please expand on what you have learned about vaccine hesitancy in relation to different ethnic groups. And then there's a conversation in the chat, so that's that specific one, around the acronym is PANDAS, as that means it's why NHS in Ealing does not treat and is not educated about PANS or PANDAS, pediatric acute onset neuropsychiatric syndrome, and pediatric auto, I can't even read, it's, can you see that it's quite a long one. Why do families have to use private care for 450 per consultation? It is inequality, as only the rich can afford it. How will you improve? Can you introduce training to the workforce? Perhaps take the vaccine question first, because that's quite specific to the topic. Yeah. Do you want me to repeat the question from Rosalind? So the first one, please expand on what you have learned about vaccine hesitancy in relation to the different ethnic groups. Do you want to? Yeah.
Oh, I will start very briefly, but we'll call on other people. So the research that I mentioned before about vaccine equity, we can send around the links to that. That's published. I don't think it necessarily looked at specific ethnic groups and reported, but it worked with a number of different ethnic communities. Just one example that's really stuck with me is when the researchers had relationships working with young people, especially in Acton. They were talking very much about circles of trust being much smaller in more diverse, more deprived communities. So young people, in terms of, say, understanding about vaccines, might listen to maybe their teachers, parents, friends, maybe youth worker, not many other people, when they were doing research in more white British, less deprived areas. You know, you'd listen to Chris Whitty's speech or something from the NHS, and that for me has really struck me, because that's not just specific to COVID, but there's really interesting research there. So that was just from me thinking we could send around the link to that afterwards if people haven't seen it. Don't know if anybody else wants to come in.
May I ask a question? With regards to workforce, the volunteer workforce specifically. And I was just wondering if you'd looked at the ethnicity and cultural breakdown of the volunteer workforce, because I think that was key to the success of the vaccination program then and future. And of course, if we've got a diverse volunteer workforce, that could be a way of properly engaging our diverse communities and possibly underrepresented ones. And it's wondered if that's being looked at.
Not specifically around the voluntary sector in terms of their profile of the workforce, but what I wanted to pick up is on the questions around what we've learned around the COVID vaccination and the various ethnicity groups in terms of uptake, particularly in phase one. It was clear that we wanted to try and ensure that we had significant population coverage. So in Ealing, as you know, it was a there was a significant level of collaboration amongst health and local authority and voluntary sector. And we set up two mega sites, one here in the Ealing town, and in fact, this very room, and we vaccinated over 1,000 every single day, as well as the one in Southall as well. But but we soon realised that there was a disparity regarding the uptake, and so particularly in relation to our Afro-Caribbean population, the uptake was, really was around the 40% mark, which from our perspective was unacceptable. And I think a lot of that was around, some of it was around false news, particularly in social media, and a lot of myth busting had to take place. But I think what was important is that we had to reach out to them rather than them waiting for them to come to us. And so we did a lot of work in Ealing with local authority and others to really find out exactly, what was their concerns about the COVID vaccination, trying to alleviate any uncertainty or anxiety about it, and really try and demonstrate to them, how important the COVID vaccination is in terms of protecting the population, because we knew and we realized very quickly in wave 1 of the COVID vaccination what impact that was having on the BAME community in terms of the number of deaths, and there was a significant disparity in that, and a lot of those were frontline workers across the entire sector of the workforce in terms who were exposed and vulnerable to the COVID vaccination. And so it took a lot of effort and time, and we did start to see that uptake improve in terms of the percentage, and there still was a disparity, and we did more or less reach to about 60% uptake in the Afro-Caribbean population. And I think what we've learned from that is it's important to use people champions to support that, people that they can relate to, and the people that they're confident in terms of giving them the assurance and the confidence that the vaccination is safe and it will protect them from this horrible virus.
Thank you.
Yeah, all I was going to say, I would echo that. So even with our staff working frontline health services, that Black Africa Caribbean, there was a reluctance in terms of taking up the vaccine, and absolutely it was using champions, other members of the same communities and background in senior clinical roles, explaining and myth busting around the vaccines and what was in it and what it contained and what it didn't contain and the impact upon you, and then role modeling, and also taking part in some of the vaccine clinics and going alongside people. So it was hard enough with our own workforce, never mind out in the community.
Thank you very much. Angela has one question, and then
yeah, just to follow up with regards to vaccine hesitancy within the African and Caribbean communities, have you shaped any of that information to influence your health and well-being strategy? Because what I think they've found is hesitancy doesn't just mean around vaccine, it could be around other healthy conditions, i.e. management of diabetes, hypertension, mental health. So have you used any of that data to shape how you will deliver services going forward?
Yeah, so I'll just mention the strategy, which we'll mention in a bit more detail in a minute. A lot of this data has come together to inform our strategy. It's very entirely focused on inequalities. So there's a number of things in my head in there which would pick that up. So there's a lot in there about community engagement, changing that relationship in terms of trust, having those long-term conversations without agendas, really working with community leaders on that. And there's definitely sections in there about making all of our services fit for our diverse population and diverse needs. So yeah, absolutely in there, and the COVID data is some of the kind of starkest evidence we've been using to inform that strategy. Anything you want to add?
Thank you. Not specifically to add to that, but I just wanted to acknowledge the question about the PANDAS syndrome that was raised in the chat. So PANDAS is a rare neuropsychiatric syndrome that picks up, I suspect fits in a uncomfortable overlap really between pediatric services and community mental health services for children and young people, and is sometimes associated with a post-viral illness and presenting in a way, for example, with the development suddenly of an obsessive compulsive disorder. I'm in danger of not giving a satisfactory answer to the person raising the question, but I think that there is probably, this is a relatively rare syndrome, but there is probably more education that can be done for both primary care, CAMS and pediatric colleagues in order to work together on this topic. And certainly if there are specific cases where individuals feel that they are having to access care privately, that's certainly something that they could raise, and I would expect that there would be a pathway through NHS services that we would be able to access for them.
Thank you very much, everybody. I will bring demand 2 to a close, and we will now move on to demand 3.
Okay, demand 3, reducing inequalities. The local authority and health agencies should carry out a review of funding priorities for Black, Asian and minority ethnic communities, particularly African and Caribbean communities who have been disproportionately left behind in the health structure and services.
Thank you, Angela. So I'm going to start talking through this. It's massive, this area. It covers pretty much everything we do on ethnicity and inequalities. So there may be colleagues want to chip in at the end if that's okay. Just going to talk this through. So sorry, it's a bit of a busy slide. So just touching especially on Sue's questions about inequalities from COVID. So we published our annual public health report about a year and a bit ago, was solely on COVID inequalities. And I don't just mean kind of in terms of health outcomes, but in terms of the risk factors as well. So a number of the risk factors from COVID were higher among some communities. So for example, we know a lot of frontline services, for example, our adult social care workforce, very diverse, multi-generational households, and the kind of both the positives and the risks that went with that. Having existing health issues such as diabetes, all were risk factors either for getting COVID in the first place or having poorer health outcomes because of it. In Ealing, especially in that first year or so of the pandemic, we did see areas with a higher proportion of people from ethnic minorities did have higher rates of infection and hospital admissions, especially Southall particularly, but a number of areas of the borough. So it wasn't just national data, we could see that at Ealing level as well quite quickly. For much of those first 2 years of the pandemic, we went round in cycles with different phases, but the rates were generally higher in areas such as Southall and Greenford. As things changed with the Omicron variant in early 2022, the rates ended up being higher in Ealing and Henwell, a little bit in Acton, a lot more among younger people as well. So I think that was more about going out more, testing more. It all got a bit messy by that point in terms of what the data was showing. But I think in that first year or two, it was really clear that we kept going back to the same areas that were higher, and you could really see that in the data. Vaccination uptake, I think as BJ and others were saying, became clear quite early on in Ealing as well as nationally about the different uptake by ethnic group. And those inequalities became more apparent as we went through different rounds of the doses. So in the first round, for example, the rates, say, for example, in Pakistani groups were quite high, whereas actually by the time we got to three doses, actually had dropped quite low. Black Caribbean communities and traveller communities were low and stayed low. So you can see the data there, and this is just for 3 doses, which is much more stark than earlier doses. You can see people from white British ethnicity with 74% uptake in the adults. In some of the other ethnic communities, travel communities, 22%, Black African, 28%. You can see that much lower uptake by the time we got there, despite all the work we'd done. But you could see the data almost, it got to a certain point and then plateaued, and you could see that quite early on. So that was where the, you know, all the work we were doing about the kind of targeted services sites, work with faith groups, etc., and the research kind of came in. But you can really see that's lasted. Just to update with some of the more recent analysis since we had the Race Equality Commission, we've had the 2021 census. I got quite nearly excited about this, but it does really show those that diversity and inequalities moving in Ealing, and it kind of shows what we already knew from kind of anecdotal and working with our communities. So we're now, it's only about 24% of the population who identifies white British. So that's really shifted since the last census. Over half of people born outside the UK, and 23,000 able to speak little or no English. So you can really see some of those, some of that data really being updated there. We've also been having colleagues doing some really recent analysis of health data by ethnic group and trying to delve into that. So this is data that looks at people who have been diagnosed and it's recorded in their GP practice. For example, diabetes, 1 in 5 adults in Bangladeshi population have been diagnosed with diabetes, so that's double the average. High blood pressure and depression, particularly high in the Black Caribbean population. But then the flip side of that is you see the data is not there for things like depression, is particularly low in areas like Southall and Northolt, and community conversations we have been having around our mental health strategy do highlight around stigma around mental health diagnosis, health seeking behaviours. So, you know, the data shows something, but you need the qualitative conversations to go with it to really find out more. And then we have been doing some interesting work around diabetes, especially in different languages, and that learning can really be applied to other conditions. So one thing I just wanted to talk about a bit here was all of this has come together to really, from where I'm sitting and reflecting on this with Neha when we were doing the slides and talking to the panel members, it's really come together to influence some work we've been doing over the last couple of years. And you can really see that through our work plans and what we're trying to do. It's not enough and there's work to do there, but you can really see it shifting. So like I said, the learning from COVID we're actively using already, especially in terms of other vaccination programs. Health and wellbeing strategy is something that we have to produce for every 5 years. We are going to be publishing it in May, so we're nearly there with it. There's been a massive amount of work across all of our different teams, our communities, our community representatives in terms of developing that, and it is entirely focused on inequalities and how we work better together to reduce those inequalities, how we work better with communities, how we look at our systems and structures in terms of reducing inequalities, and how we look at what we call the building blocks of health and wellbeing. So that's everything you would think of in terms of education, housing, employment, yeah, lots of things. So under there's a very long list, but really thinking about having a well-being and inequalities lens on that work. And so that's will be published soon, and it may be at the next meeting of this we can share that, and we can share the link when it's published. Neha, do you want to cover about the core 20+5?
Yeah, so there's a nationally produced framework for how to tackle inequalities across the whole country, across the NHS, and it's called Core 20+5. So it's about core services and making sure all of those core services tackle and make sure are universally covered. It's looking at the 20% most deprived population, or those that aren't accessing services, and how do you do focused work to ensure that they are supported and pathways are tailored. It's looking at the plus population, which is then looking at certain population groups as identified by Anna in one of the first diagrams, first slides, where you've got certain population groups that aren't accessing services. And then 5 clinical areas. And there's a similar, it's very recently published for children. And the idea is that if everybody's working on these inequalities and all of the work that we're doing as a collective, we'll start to have a really positive impact, because you're really delving into the details. And we're doing a lot of work on that already to reach out, and following the pandemic, to reach out, and all of our teams are involved in this to a certain extent from every single part of the system.
You. And then just to cover the other points, so there's a lot of learning from what residents have told us work. So for example, text messaging individuals if they need tests. We've also got this next point hides an awful lot of detail, but there's a lot of work we're trying to do in terms of either service delivery or engagement or conversations about reducing stigma with different community groups. Some of that's by ethnicity, some of that's by need. So for example, asylum seekers or homeless or TB. A very recent example where we've had some funding recently, and we've been working with some of our local voluntary services, especially GOSAD and I think Anglo-Caribbean Society, working with them to actually run engagement events and discussions and learning around things like mental health, children with additional needs, and really thinking about with our local health partners and how we have some of those conversations and share some of that learning. So small but good examples of how we're taking some of that forward. Simon, I don't know if you want to mention the hospital strategy in terms of the equitable care part. It's on the slide, but I thought I'd pass it over to you rather than me reading it
Oh,
off.
the bit I said it, yeah. So yeah, I think I did say it in my intro when I talked about developing our new strategy, that one of the things was about making sure that we were, as well as equality in our workforce, it was about equity and access to care. So when we are looking at new interventions and new services, and certainly some of the outreach services in the community, we are trying to make sure, again, it comes back, I used this phrase earlier about monitoring the data in terms of, so in terms of the service being accessed. So if you take things like the heart failure clinic and the heart failure lounge in Ealing, we're looking at the profile of patients who are accessing that, and we're doing that elsewhere with other services. But so as well as we talk to our workforce about being equitable within our staffing, we are very much focusing on equity of access and monitoring that outside the hospital as well. So again, so a piece of work. I chair the frailty working group in Harrow, and again, one of the key things that we're looking at is the profile. So there might be older people, and so traditionally we've just looked at their age profile in terms of accessing that service. Increasingly, we're looking at the ethnicity of that population, and also comparing it with our admission profile. So are we providing the right support into the outreach to the community to try and prevent the inappropriate admissions into hospital?
I just thought it might be helpful to share the perspective from the Mental Health and Community Trust alongside the work that Simon has described. So as well, I guess without wishing to repeat, we're doing the same work in our organisation, looking at access, and I'm sure that the same is true for London North West, but also looking particularly at the disparity in outcomes for individuals and in the experience of care. So there is particularly a disparity that we're aware of across mental health services across the UK about the use of restrictive practices in mental health settings. And this is something that as a trust we are explicitly examining to try and understand whether individuals from certain ethnic backgrounds are more likely to experience restrictive practices, more likely to find themselves detained under the Mental Health Act, or being secluded, for instance, in the most extreme examples of inpatient mental health care. And I think that's really important to us within the organisation to look at to look critically at ourselves around access, experience, and outcomes for different ethnic groups.
So just a couple of final points, if that's okay. Thank you. And then just a final point on there was just saying our NHS North West London footprint is also developing a strategy at the moment, which should be out, I think, later in the spring, early summer. And we've had opportunities in Ealing to input into that. And there's an aspect of that that's looking at kind of wider population health and inequalities, and really trying to, we've been working with them to align it with our health and wellbeing strategy so that we're all kind of moving in the same direction. So just two final brief slides. So one of the ways in which we have been trying to push this further and faster has been by actively looking for and gathering resources. We've had some NHS North West London inequalities funding is coming our way. So we've been putting in bids for that around things like analysis, qualitative research, peer research, engagement, targeted services, and for working with our community voluntary faith sector. We've had some money put aside from my budget to run an inequalities fund. So that's just been launched at the moment. So teams and hopefully working with community partners can bid for that. We've also had council funding set aside for taking forward the Community Champions programme. It's a piece of work that started with COVID money, and we saw it was important, so we've been taking that forward. I think we're now up to about 35 champions, so it's still early days, but I think really importantly the champions themselves have been setting their own priorities. So it might be linked to ethnic communities, it might be linked to age groups, it might be linked to certain topics that they want to cover. So that's not just health, that's much broader in terms of people's well-being. So we've been doing a lot of work around things like cost of living. We've also funded a couple of roles that did some of that analysis that we showed before. We've had this ongoing research project with our academic partners looking at kind of health equity and having those conversations with communities about what are the assets out there that support people, how can we build on those. And we're also considering a bid at the moment for a very large funding that looks at our research infrastructure, which includes working with our community groups. So that would be really exciting if we get there, but early days. And then just very finally, in terms of next steps, we'll be working over the next month or two, especially in light of the health and wellbeing strategy, in terms of what's the action plan for that, but also what does that mean for our borough-based partnership in terms of priorities, and really thinking about the work plan for the next, annually, in terms of really better understanding and reducing some of those specific inequalities, and thinking about corralling all of those resources together to really drive that work. Publishing, taking forward the lessons learned review, learning from community champions. It's still early days, really good conversations with our champions about how that's going, and really working with our community and faith leaders there as well. Continuing and further strengthening programs that have had a positive impact. So, for example, messaging around screening. We've got peer researchers out in the community. It's very small numbers. We've got funding to take that forward. So that seems quite exciting in terms of actually having our own communities doing that research with us, rather than somebody external coming in and doing it. I think that'll be really powerful as we go through time. All those different funding streams I mentioned, hopefully coming online in the next few months. And then finally, we're also going to be publishing a profile of our 7 towns. So like a mini needs assessment, but by the 7 towns, with a focus on inequalities. So it's a first cut of it. There'll be work to do to improve that, but it's just a different way of us looking at things. I think that's all. Thank you.
Thank you very much. Thank you very much, panel. Have we got any questions for the panel?
There's a question by Anonymous. It's more a statement, but I think in fairness and transparency, we need to read it out. It says, people need to be free to make up their own minds about the COVID jab. Claims about vaccine safety are seriously overstated. So, and then there's some others I think we can probably respond. But there's a statement again. I'm not sure if the panel wants to take. What happens when a patient without their consent, as well as family members' consent, or say were placed in a care home, which in any way met their needs. So not quite sure if this is, oh, and then there's not. Yeah, do you want to, and then there's a third one. How are you engaging with those who do not associate with faith leaders? Yeah.
Sorry, the first one, I didn't really catch the fullness of the question.
It wasn't a question, it was a
The
statement.
statement about people can choose about vaccine statements. I've just
I heard the bit.
Yeah, and then I wasn't quite sure. It's not quite clear. So Chandra, I don't know if you want to retype, but I'm going to read out as it states here, what happens when patients without their consent, as well as family members' consent, or say were placed in a care home, which in any way met their needs? Not quite sure. The question there sounds like a, but then the next one, yeah, how are you engaging with those who do not associate with faith leaders? Yeah.
I'll start that, others might want to chip in. I think when we talk about working with faith leaders, that's one aspect of everything we're doing. So as you know, members of the community leaders, trusted voices, I think it's a really important part. We had a faith forum through the COVID pandemic and was really, and also faith representatives on some of our different groups. When we were talking about community engagement, thinking about messages, thinking about how to deliver vaccine programs, etc. I think it was really powerful, but it is only one aspect of that. So yeah, using those relationships that are out there and building on them, but as part of a wider program.
Yeah, if I can add to that, actually a lot of the work we did wasn't only with faith leaders, it was other community leaders, but also directly with individuals as they were coming to vaccination clinics. Their programs developed, actually. We had CP House that has been a long-standing vaccination clinic, and they developed their model even further. So as people were coming in for the vaccination or just querying about whether they wanted to, just finding out information about whether they wanted to, we were using that as an opportunity to do other types of engagement work. And over the last few years, and as part of our strategy going forward, that engagement through various routes, through residents forums, just through communications, through newsletters, through conversations with GPs or other frontline staff, community pharmacists, all of these routes are really important to engage with people. So that collective workforce we have across Ealing, it's not just those people that are sitting around this table in those organizations. There are voluntary sector organizations, pharmacists, dentists, optometrists, everybody that we need to capitalize on to have those conversations.
So mine was about the discharge question or statement. So this is a general comment I'll make rather than anything specific around what may or may not be that case, is that you know, over the last 2 years, the hospitals have been under sustained pressure in terms of the volume of patients being admitted through the emergency pathway, and most people will be fairly familiar with, it's not just Northwest London, but the national press in terms of holding ambulances and patients waiting in ambulances for offload. And part of the reason for that is because the A&E departments are full with patients waiting for beds. So a decision to admit is made. And so quite often we will come in a morning, both for the Northwick Park site and Ealing, and those A&E departments have patients waiting for a bed. They cannot access a bed until a patient is discharged. So if patients are medically fit for discharge, yes, we do try and engage families in the conversations around choice, but it's not always possible to satisfy that choice. And what we have to bear in mind is this patient is stable. They finished their need for a medical bed and taking up a bed in the hospital, whereas the patients waiting in A&E and waiting for ambulances desperately need that admission into a bed. So unfortunately, there are times that relatives are not always 100% happy with the destination of the discharge. But those are care homes and placements that have been assessed as being appropriate for those patients by appropriate professionals in terms of doing it, and their accredited entities. But it is a challenge on time, and we can't always satisfy patient choice because the main focus has to be the clinical need of the patients waiting for a bed.
Thank you very much. Thank you. Are there any more questions? Yeah, okay.
From Suzanne Fernandez, hesitation from university students, international students who are living at student halls in the borough and not registered with a GP. How are they being reached regarding vaccinations?
I think it's a really, really important question. And that's where the national booking service is really critical. You don't have to be registered with a GP to access a vaccination. And if our students aren't getting this message that they can go on the national booking system, if they are within the cohort that can get the vaccine now, that is, they can go on the national booking, anyone can go on the national booking system and book into a pharmacy slot. And we have quite a few pharmacies in Ealing. But if there's anybody that still needs a vaccination, there are a number of routes through which they can get that. And if we need to improve our communications, happy to have a conversation outside of this if we can be contacted directly.
Thank you. Okay, we've got one more question.
Slipped in just now from Jag Sangera. Great to hear that such a variety of methods are being utilized aside from the faith leaders to communicate with residents. However, has any analysis been done as to what works well in which areas? So going forward, engagement is more targeted. Appreciate during the pandemic, it was very much an emergency response. And then shall I just quickly do the other question? How can we expect the publication of the 7 town profiles? Dio, or when? Sorry, when? My eyes. It's from Dio.
I'll start with the first one, but quite a high level response. Apologies. I think there was learning from the COVID pandemic, and I think some of that will come out from the lessons learned. I think some of the answer is variety, different things working, different parts of the borough with different groups, and I think it's having that very broad approach. We have been working with these academic partners in terms of that learning, and I'm hoping that we'll be able to do that going forward as well, both in terms of pandemic, but more generally in terms of what works locally in Ealing around community engagement. But I think it fits very nicely into the health and wellbeing strategy, so I think there's work to do there. 7 towns profile early summer, I think.
With quality.
Obviously not entirely clear what the specific concern is that's being raised, but the general principles around this would be, I think, for both organisations or for any NHS organisation providing care for Ealing residents, the usual process is to raise a complaint with the trust. If that's not satisfied, there's usually a second stage process that involves further discussion about the complaint that's been raised. I think we all welcome communication with the members of the executive team if you feel that answers have not been responded to adequately. Individuals can communicate with the CQC directly by Googling them, and the information is then passed to the trust, and the CQC monitors our responses to CQC inquiries. And finally, when other avenues locally have been exhausted, the Parliamentary Health Service Ombudsman is able to scrutinise what local health organisations are doing. I hope that provides some guidance.
Thank you. Okay, Sue, you've got one question.
To comment actually to the, I think there was a comment or question about people being able to make up their own minds because the safety and risk so vaccination have been exaggerated or have been not put forward properly. And I just want to comment as a health professional myself that we have a duty to do things in an evidence-based way. And there is, I think, a big body of evidence about the vaccines, their effectiveness and safety, and of course risks. And the decision, of course, is for people is about balancing those risks and benefits. And getting those messages across is the challenge for our health and public health partners in a way that's understandable, and potentially repetitively. People are going to need to hear it multiple times in multiple contexts about multiple vaccines, because we know what happens when we don't have enough people taking up the vaccine. I mean, as a child mental health professional, I've seen the damage done by people not getting, or children not getting their MMR vaccinations. That's not something anyone should have to deal with.
Thank you very much. I know I can see there's quite a few questions still in the chat, but what we will do is we will take those questions and we will answer them and they'll be published. So I'm now going to bring demand 3 to a close. Oh, Angela's just going to.
Yeah, sorry, Denise. Just before you close off that section, I think we would like to add that this is just the start of the journey that we're working with yourselves. There's a lot of information you've provided, and I'm hoping that this process doesn't stop here, that it will continue, and you can use myself and other panel members as a soundboard to actually look at some of the work you're doing, and we're quite happy to comment and give you advice and give you support, because as I said, we are residents living in Ealing, and we are just another voice that can help shape some of the services that you plan to deliver. Thank you.
Well said, Angela. Thank you. Okay, so I will then again bring demand 3 to a close. I wanted to introduce Councillor Josh, who's already obviously stepped in and said a few words, but I don't know if he wants to come back and say a few words, and then Councillor Aisha Raza, she would like to say a few words after as well, please. Thank you.
Thanks. I don't think I've got much to add to my earlier comments, but just to thank you to everyone for the questions and the contributions. Obviously, part of my role is holding the NHS partners around the table to account along with you, but it's great to have so much enthusiasm in the room for those demands. So thank you once again for your time.
Thank you, Councillor.
It's been really insightful actually to have everybody here today. So it's been wonderful to have so many people online and everybody engaging, and so good to hear about how the recommendations of the REC that we've been addressing are being built into our health systems, a lot of them already. So it's been quite heartening to know that work has started on that already, and it's not just something that's sort of being done because of our demands. So that part of things have been quite good. Also, there've been lots of interesting range of questions, so it's been quite nice to sort of give us other things to go off and think about. I know Anna always has a big long to-do list, so this is added to that. And this work is ongoing, like you said. I think this is just the beginning. This is the foundation. We want this to be like a space where people can have this conversation and keep sort of adding to it. So this doesn't feel like the very first one. That this becomes part of our normal way that we have this discussion with people, with our residents, with our healthcare professionals. We also just want to make sure that everybody feels they can access this. So sorry if any glitches that have happened today, given that it was the first one, but this should become some place where people feel they can come and engage with you, and that you can hold us to account. So thank you for having us. I'll just add my thanks to Josh's and say that it's been really, really insightful. It is up to all of us to make sure that we make things better and fairer and more equal for everybody. And this is the way that we sort of started this process. But it's up for everybody to make sure that we continue this good work. So thank you all for coming, and thank you so much for inviting me along.
Thank you. Thank you very much. Well, I'd like to thank all the panel members for coming on. There's a couple extra people that I wasn't expecting, so please bear with me. So thank you to Anna, Neha, to Simon, Chris, Vijay. Thank you very much for attending. I know one person already had to leave, but we thank her as well. And then thank you to the Citizen Tribunal for coming along, and actually not just coming along today. As you heard, we've done spent a lot of time speaking and having meetings with the NHS and the health people in the room. Thank you for those people in the background who are making sure that everything's working properly. Thank you, Councillor Raza. Thank you, Councillor Josh. Thank you, Councillor Mason. I'm sure you're listening somewhere and you'll be watching back what's gone on today. And thank you everyone in the audience who's come online to observe, to listen, and to put your questions forward. There are 7 priorities, so we still have another 6 priorities to talk through. So please watch out and look for when they're coming up, or they're putting them on the screen. Okay, so the next, we're going to have these conversations. These conversations are going on already, and we just want you to hear the conversations and be part of the conversation and the changes that are going to happen within the Ealing Borough. So thank you all again for attending, and we look forward to seeing you again soon.
Could I say thank you to Denise for excellent sharing? So thank you very much.